sana kwa nafasi nyingine tena. Naomba nitoe taarifa ya uhuru. Yeye amenipa ipo ofisini mara moja kwa ajili ya majukumu ya kazi, kwa hiyo ameenda kwa ajili ya kutekeleza majukumu. Pengine akipata nafasi anaweza kajoin tena baadaye. Kwa hiyo karibu tena kwenye nafasi sehemu ya pili ya presentation. Mimi pamoja na James tutakuwa na presentation fupi ambayo inahusu screening of risk factors for cardiovascular diseases. As I've told you at the beginning, we have this cardiovascular risk management project where we've been dealing with screening and follow-up of people having cardiovascular diseases, hypertension, and actually we've been also being attentive to some elderly conditions. So we've conducted several screening events for the duration from 2023 up to date, and we have the data from screening, and then that's what we are going to share in our presentation. Also, as Dr. said, we need to disclose our interests, as we are not dealing with any business or we are not participating with any company. So this presentation will be clear that we don't have any interest in any company or any specific needs, not interested in the advertisement of any specific company. The first slide talks about the global burden of the cardiovascular diseases. As we have said, this is the global map showing the burden of the cardiovascular disease, and the red mark the areas with high prevalence of the cardiovascular diseases, and it's marked by the standardized disability adjusted life years. When I say disability adjusted life years, I mean number of years that are lost due to people falling ill because of the cardiovascular morbidities or premature death. Si kama tunaelewana. Naomba nizungumze kwa Kiswahili. Ni kwamba tunaposema disability adjusted life years inamaanisha miaka ambayo inapotea kutokana na watu kuwa katika hali ya ugonjwa, kwa sababu ukiwa mgonjwa siwezi kufanya kazi, kwamba huwezi kufanya kazi, au kwa sababu ya mtu amefariki kwa sababu ya ugonjwa yaani kabla ya muda wake, kwa sababu ya magonjwa yasiyokuwa kwa mfano magonjwa yanahusu masuala ya mfumo wa mzunguko wa damu. So that's what is the disability adjusted life years mean. So this one, I got this from the American journal, where they tried to put the global map, and they did the meta-analysis from 1990s up to 2021. So this is what they've seen as the global burden of the cardiovascular disease, and they are the ones who developed also this burden definition of the disability associated with life years. So you can see we are Tanzania, and we are here. So who can reach the this one reach with this, right? So we have this range of years that's been lost among 1,000 lives as to all these years are being lost because of either someone is ill, not capable of performing his or her duties because of the cardiovascular disease, or someone dies early before, we call it untimely death. So that's what we have. So we are losing this amount of years. So it can also, if we have put up an economist here, we could have made like the translation simply to monetary terms and economy, how this is affecting our society. Next. So in Tanzania, like many countries in East Africa, the burden of the cardiovascular disease is increasing. There is rapid growth of modifiable and intermediate risk factors which are accelerating the cardiovascular morbidity and mortality. Within a group of non-communicable diseases, cardiovascular diseases are the number one cause of death in Tanzania, as I think you read from the previous presentation. So primary prevention through an improved health system, including affordable healthcare services and health staff with adequate instruments and the needed key actions. This is as to the research that was done by Roman in 2019. So you can see one of the key step in management or in reduction of the cardiovascular related morbidities and mortalities is through having affordable healthcare services. We need to have the healthcare services which are affordable for majority of the people, and we need to have people or staff who are trained there, ready for giving the required care, and we need to have the supplies necessary for the proper care to be given to the community. So with the government's effort to improve in infrastructure and personnel for health service provision, people can be prevented from complication from these diseases. There remains a gap in attaining basic quality of services among individuals. Tanzanians, attributed to factors like low level of income, has been one of the factors that has been hindering the attainment of the quality care associated to these cardiovascular diseases. Inequality in technology advancements in the rural vis-a-vis urban areas. As we know, and most of the Tanzanian setting, the urban setting are well, do have a lot of like facilities, and more of the personnel that are well educated are always tend to work or want to work in urban rather than in rural areas, and then they are leaving the rural areas like the Serengeti as one of the areas where we are underprivileged when it comes to the care of the cardiovascular diseases. So we have also another factor like lack of awareness on public health among majority of people, and this cut across all the places, even in urban or rural areas. We have very big gap when it comes to the understanding of basic community health. And inadequate skills and knowledge among primary healthcare providers who are catering for majority of the large chunk of their services to most of the or majority of the population. As we know as of today, more than 80% of the Tanzanian population, they are living in rural areas, and with that, more than 80% of the healthcare services are being provided in the primary care facilities. When I talk of the primary health care facility, I mean all the way from the dispensary, health center, up to the level of the district. So most of the people are getting services, or they are in an area where when they need service, they need to go to the dispensary, they need to go to the health center, or they need to go to the district hospital. So that's where, if there were some research that has been done. It has shown that the providers in the facilities are not well knowledge about the caring of the cardiovascular diseases. So, as part of the solution, we have the cardiovascular risk management project, which works in which we detect people at risk, and we provide patient education for prevention of diseases and complications for people living with cardiovascular diseases. So here the slides show the pictures that we have seminars in our project. We had screening exercise. You can see some people engaged in the screening. You can see people waiting for the screening. That was beside her, right? And here are some other. You can see Dr. Maya, who is now working in taking care of that elderly woman. Where was that? Yes? Yes. So you can see that's what has been done, or that's what we've been doing in our cardiovascular risk management project. But also those are the posters that we have been using them in giving or in making that people are getting their education. So here I'm going to present on the results of screening that we've been doing. Because I've just chosen sample of some screening that we've done for the purpose of the presentation, but we have more than this. But this is, we did this on the 14th of November 2023. It was during the Weight Diabetes Day. Like tomorrow is going to be the Weight Diabetes Day, right? So tulifanya zoezi la screening. Naomba niweke sasa kwa Kiswahili kidogo kwa ajili ya kwa tuliweza kuona wateja 126. Kati ya wateja 126 ambao tuliwaona siku hiyo ya kisukari duniani, watu 7 ambao ni sawa na 6% walikuwa na kiwango kikubwa cha sukari, ambacho tulikipima kama uwepo wa kiwango cha sukari cha zaidi ya millimole 11.1 per lita, na wengi kati hao walikuwa wameshai kuambiwa kwamba wana changamoto ya kisukari, lakini hawakuwa kwenye matibabu ambao ni ya mwendelezo pamoja na ufuatiliaji wa mara kwa mara. Lakini kati ya watu 126 ambao tuliwaona siku ya kisukari duniani, watu 54 ambao ni sawa na 43% walikuwa na kiwango kikubwa cha shinikizo la damu, ambayo sisi tulitemu kama ile kiwango cha shinikizo la damu zaidi ya 140 kwa 90 mililita za mercury, na ambapo katika hao wengi walionekana walikuwa na wanaume, na wengi ambao walikuwa na kiwango cha juu cha shinikizo la damu, hasa wale katika ile stage 1 hawakuwa na dalili hizo ambazo tulikuwa tunaziangalia, ni kama kichwa kinauma, kama walikuwa wanasikia mapigo ya moyo haraka haraka, lakini pia kama walikuwa wanapata shida kwenye uono. Next. Sorry, I'm repeating the slide in English because we need. I wanted to communicate the patterns, right, for some specific reason. So we screened 126 clients, and out of 126, 7 of them are the elevated blood sugar. When we say elevated blood sugar, we are taking the random blood sugar of more than 11.1 millimole per liter. And majority of them who had high blood sugar, once been diagnosed with or were told at once that they are diabetic, but they were not on any follow-up. But also, of the 126 clients that we screened, 54, which is equivalent to 43%, had the elevated blood pressure, which is where we took the elevated blood pressure of more than 140/90 millimeters of mercury, and the right percent was observed among men, and those who were elevated, most of the clients whom we found had elevated blood pressure had no symptoms, especially for those who were stage 1 hypertension. And the symptoms we are exploring are headache and awareness of heartbeat and black vision. So that underlies the need for screening, because even with that asymptomatic hypertension, there are possibilities for the organ damage. So without screening, without doing what the first presenter was saying here, we can miss some people who are really at risk, and then they just develop complications. And mind you, whenever as the stage goes down, is when even the intervention is simpler. Because with stage 1 hypertension, as the first presenter said, you can start with even lifestyle modification that can help. Some people, they don't need even to go to medication, just adhering to exercise, following proper way of dieting, and then the pressure is controlled. But if we don't detect it, then we just wait, and then it comes to be a good control. Also, we scanned about, we also scanned about obesity. Here we are taking the body mass index, where we were taking the body mass index ranging from 18 to 24.5 kilogram per meter square. That was the normal body mass index. So among the screened clients, 19% were obese, which is going to 24 people, and 42% were overweight, that's with a body mass index of 24.5 to 30 kilogram per meter square. And we had 4 clients who had body mass index coinciding with underweight. So you can see, if you take 19% plus 42%, it's around 61% of people whom we screened had high body mass index. Next slide. So here is that you can see the head weight was 36%, and the rest, most of the clients whom we saw were either obese or overweight with that percent. So we need another screening. This was just outside the hospital, where we did it on 25th and 26th of June this year, where we screened 118 people. Among screened clients, 10, equivalent to 8% had elevated blood sugar. And that's the definition, that was how we were defining it. And actually, as the rule, most of them were once diagnosed, but they were not on follow-up. A few were unaware, although experiencing the symptoms of long-term high blood sugar, like the frequent urination and weight loss. And this should also be one of the key things. There are these people always, when we are doing screening, we find someone is experiencing some symptoms that he or she doesn't know exactly what's the problem, and you just find like the blood sugar is high. So we need to be always following. And among screened clients, 37, which is equivalent to 1% as elevated blood pressure, and with this screening, highest percent was observed among women. And some of them experienced symptoms of high blood pressure, but were treated for different conditions. And this is something also we should also go with. Because there are times someone is experiencing bad headache, is experiencing like awareness about it, you go to the and then you have like the painkillers, or there are people who are sometimes treated for urinary tract infections, some others were treated for malaria, and while they had the elevated blood pressure. So we should be very cautious and always screen for all the clients coming to the facility for this cardiovascular disease. Yes? So here we use the waist circumference as a measure of obesity. So we, as the guideline, the waist circumference for women below 80 was considered 80. And for men, the waist circumference below 94 were considered 80. So among screened clients, 67, which is equivalent to 57%, were found to have high waist circumference. So you can see the percent. And actually, we estimated some were to be with the cream, because the waist circumference doesn't tell about the underweight, but we estimated that we had some who are in. Maybe 13, which is equivalent to 11%, we are considered to be at risk of underweight. And most of obese clients were females, and the underweight clients were mostly males. Next. So here is the results. Next. And we did the third screening on the market and report today, where we had 93 people who were screened. Among the screened clients, 3 had elevated blood sugar with the random blood glucose. Next. And 37 had elevated blood pressure, 35 is 37%. Next, among skin, and 54 were found to have high waist circumference. That's the obesity. Next. So from all this screening, we can make some deductions. There are a significant number of people who document with risk factors for cardiovascular diseases. And as from the data from this screening, 3 up to 5 out of 10 screened clients has elevated blood pressure. I mean, watu watatu mpaka watano kati ya 10 ambao tulikuwa tunaona kwenye zile ya screening walikuwa na pressure, shinikizo kwa damu. Lakini watu 6 mpaka 7 kati ya 10 ambao tuliwaona had obesity. During the screening, there are people who are found to have elevated blood sugar. The prevalence was a bit low, 3 to 6%. But this should be taken with serious, because even with this low percent, the complications are very, very, very bad. So, go to the next. What are the issues that we observed during screening? We have significant number of screened clients who are not on follow-up. Most of people who had these cardiovascular conditions were not on the specific follow-up. Patient follow-up needed continuous education. We found we have these clients whom we diagnosed for the first time during our screening, and the others even who were on follow-up. We had the impression that these patients need always to be educated, or they need to have, because there are a lot of things that are happening. You cancel the patient today, he or she goes somewhere and have another type of counseling, and then when she comes back, she has different ideas from what you started with. So you need to continuously educate the patient, you need to continuously counsel the patient and change as to what the patient's complaints is raised, because there are times patients may come on medication and then they have the side effect, then you need to educate about the side effect. But the patients are feeling like psychologically that someone can tell you, like, you know, I've been on medicine for some time, but I was just thinking, would I stay with medicine for my lifelong? Then you need to properly understand and educate him or her accordingly. So we need always to have education education sessions when we are training patients with these cardiovascular diseases. Some elderly fragile patients had conditions complicated with other geriatric conditions. So we had these elderly patients whom we are attending during screening and during the follow-up of these patients, and we found like there are other age-related conditions that were not attended. It's very common that if someone is having high blood pressure or someone is being treated with blood pressure, when she comes to the hospital, someone deals with just refilling the drugs and taking the blood pressure, it's okay, then you go home. But there are these, we found like there are some elderly or age-related conditions that were also affecting the blood pressure, like pain among elderly. There are these patients who may be coming with pain because of some like the arthritis and other stuff like that. Then they need to be attended when you are also following for the blood pressure. Patients needed more time during consultation. Patients needs attention and time during consultation to address all the issues. Healthcare workers at primary care facilities lack enough knowledge to care for cardiovascular diseases and their risk. In most of the primary healthcare facilities, most of the healthcare workers are not well educated about how and when and the way to care these people with cardiovascular related diseases. And some complications are detected late on the course of treatment of cardiovascular diseases. The screening of complication, there are some of conditions that are not screened properly always during the visit of these patients. So we need to strengthen the way of screening for complications like the peripheral arterial diseases, like development of some eye complications. Some people are losing sight when they're on medication and on follow-up. So these are things that also need to be followed closely. So what do we, from the screening, from what we've observed, then we think this should be the new look of the project. We need to strengthen screening programs. They should be enhanced in several places to reach a lot of people. And we enhance patient education programs on non-communicable diseases. We keep special attention should be paid to elderly patients because we don't have the geriatric specialist, but Dr. Ma is the one here. Maybe she can help us a lot on that because there are special attention that needs to be paid when you are taking care of hypertensive old man, are different from just the other. Even the blood pressure targets are different, right? So we need to promote education programs among healthcare providers at primary care facilities. As we are doing this seminar, these are the things that we should always promote them and have them as much as possible to make sure that everyone is aware of what's happening in terms of the cardiovascular program. And we need to enhance continuous screening for complications and management of the cardiovascular diseases. And that's why even in this project, Dr. Ma will lead us in measuring of the so-called ENCO blood glucose index. It's very easy, but it can help you know that the patient is at risk of developing the peripheral arterial disease, and then we make early intervention to prevent all the complications, including even amputation. Thank you, and I think James is going to present another part of screening that was done in Bedside, and then we can come to the questions.
So I'm going to present the statistical screening data which were conducted at Bedside Health Center from January till October of this year. On previous year we had some screening and some of the data I've just kept them, but at January till October. As you can see, on January we screened about 21 people. Like 3 patients where the female were 21 and the male 8. And on May we had 30 patients where the female were 18 and the male were 12, and screening on the May Day and on special clinic day on June, where we obtained 63 on May Day, 63 patients, where the male were 45 and female were 18. And on a special clinic on June, we screened about 53 patients, where female were 13 and male were 40. And on June, we had to screen 33 patients, where 11 were male and 22 were female. And on July, we had 16 patients, and where male were 11 and only 5 were female. And on August, we had to screen 22 patients, where 15 were male and 7 were female. And on September, we had to screen 27 patients, and where 19 were male and 8 were female. And in October, we had to screen 30 patients, where the female were only 4 and male were 26. Now you can see the total amount of male were 221 and the female were 173. The total amount is 394. So this gives us the clear picture of what we should do toward on this project, on how to help the community and improve awareness of all cardiovascular disease. So here is the data interpretation on the above data which you have seen. So the proportion of the risk factor, according to the above data from January till October, the 23% of the people we screened were found with hypertension, and 17% of the people we screened were found with diabetes, and 25% of the people screened, we just analyze that their physical inactivity means they don't make themselves on physical exercise, and 6% of the people screened were found smoking, with a smoking habit, and 29% of the people screened from January to October, we found 29% had obesity. So you can see the clear picture of the people screened from January till October. That's a clear picture of the data. So that's it. So any question from the where Dr. Edgar began until here? Welcome.
Any comment?
Thank you very much both for your nice presentation. It's very good to see all the work of the last year put together, how many patients we have seen. But also I noticed a big difference, and I don't know if you understand yourself. In your screening you showed there's you had a small prevalence of diabetes, lower than the estimated ones in Tanzania, and in Musoma you have actually a high number of diabetes. Do you know actually what could be the cause? Were there so many patients with diabetes in Bethsaida, or is anything, because the difference is quite big? I was really wondering.
Yes, thank you, Doctor, for the good question. I think the difference would come and lies from the type of the glands, because we had a different kind of screening, because we started with we have the screening that we did during the West Diabetes Day, when we went down there, and when we had that big tent and everyone was coming for screening. So, and after the first setting we had 10,000 doses and people were coming for screening. The other one is during the Rule Touch and the Market Day. So we brought the tents and people were coming for screening. So the difference in Bethsaida, I think most of the screening were done at the facility. It may be because most of the people who are coming to the facility directly for screening would be feeling kind of people, and maybe some other guys were just roaming around, and they had some, maybe they went to the market for some shopping or what, and then they found a screening. So I think to exactly, we were below the urban, would have the different picture. We don't know. Also, so many big urban as compared to maybe. But those are the factors that need to be explored.
I think we come across most of them come directly to the hospital, because the screening mostly is done at the facility. We don't go to the other area. So most of the people comes in are practically ill. Yes.
Maybe because of people know now, if I have diabetes, I should go to Bethsaida.
Yeah, and since we
Which is also
and since we did a promotion to, we make some posters and distributed to around the place, so people are like knowing that they can get help to Bethsaida. Some of the medication which we bought, so sometimes we give them like free, and some people, that's how people can increase time to time. Yeah.
Thank you for your good presentation. Maybe my question is that by the time you are doing your screenings, I think there are people who are coming from the rural areas, coming to the hospitals. So, do you think for these ones whom you have already screened and you find this high risk of hypertension and diabetes, is there any follow-ups that you are making in order to know that maybe our patients we have met in this session, they are coming to get maybe the medications or some other advices? Is there any follow-up?
Maybe Dr. Tan can have
Yes.
a response about that.
Yes, thank you very much for having me speak here. So especially in our center here in Lady, most of these patients are coming from outside, not inside. But when you need, and the problem which I make is that once you give them medication, they don't want to come for follow-up. So we get difficulties sometimes to pick them properly. Yeah, some when they are in the medication, once they go outside, some patients they refuse to continue with the medication, or sometimes they fail, they deny to come to the hospital. Till when they get the severe complication, that's when we see them again in our clinic or in the hospital. They're in bad situations or sometimes in a complication. Yeah, that's the problem. I think we have no proper way of catching them instead of returning them to come to the clinic.
And maybe to add on what Dr. Tan has said, you have the elderly clinic here. Actually, it's elderly plus the non-communicable diseases. So Dr. Tan is the one who is coordinating it. And whenever we have these patients, we schedule them to come for the follow-up. And he's always there for them. But something he was trying to explain is, there are these people, because of maybe the way we communicate, maybe we are not being so nice in communication, maybe, so we need to improve on that. Or because of the other, we are not we are not confining our patients. They have a lot of education, a lot of counseling here and there. So there are these people who, if you start, you go on medication today, you go somewhere and then you have some other advice. We have a lot of herbal medication around. We have some clients who has left our follow-up going for that. So that's sometimes brings people out of this follow-up we are instituting. But we have the formal way of following them through our elderly clinic. Whenever we have someone with hypertension, even those who are at stage 1, we just cancel on lifestyle and then we ask them to come at the clinic. I think Dr. Tan, you should maybe you can tell if how frequent do they come. But I know there are those who are still visiting us for
Yes, normally we give the time to come back to the hospital after 1 month. 1 month follow-up. If it is severe, then they should come at any time. But normally we give 1 month time for follow-up.
And what of for those that, maybe that one you have talked about, those who are already on drugs, but what of those you have seen the first time and they were not aware that they were in that high risk and they have not yet started taking the drugs and they never knew their conditions?
Yes, as Dr. Erika said, once we educate them on how to continue taking medication, once they, when they turn back home, as he said that time, they may get some different opinions from others that they should take this, or sometimes they provide they tell them not to continue with this medication, or sometimes they switch to herbal medications. Yeah, that's how.
But there are quite a number of people who are still on follow. It's not that all, but we have some of them who are dropping out of the follow, but we have quite a good number of people who are still on follow, coming every after month or 2 months, depending on the condition for follow. We have them still, yeah.
Thank you for your good presentation. We are learning something, and I know this will really help us to help people in the community, especially for awareness. I'm just asking, how is your catchment area? Like your patients, how far do they come? Is maybe transport coming back, and that also be a challenge, maybe for follow-up, or how they can travel, maybe they need to take a motorcycle. Is that also a factor that you think can make the road come back?
Yes. Thank you very much. Thank you very much for a good question. Yes. The catchment area of here, most of our patients they are scattered in different areas. Therefore, some of them they usually use the border to come to the hospital. Sometimes they use their own transport by using legs or sometimes bicycles. Yes. The transport here is also very factor.
I think to add on, the geographical and infrastructural structure of Serengeti is diverse, and actually most of the areas are so remote to the extent that you cannot bring a car there. There are places where you can just go by the car and then you use everything you want. And people, we have few areas with like community, like buses. Maybe you want to go to Machosho, where there are few areas where there are those transport. So, and the infrastructure is not so nice. So there are people who may be not coming here because of the infrastructure too. And actually, even with the weather, is another problem. When it's raining, there are places which is completely unreachable, so we can miss some of them coming because of that.
Do you have volunteers, or you've not started that process? Volunteers maybe coming from different areas that can reach them and connect with you. Maybe you may think of that.
And that's another thinking we can have. Like, we have like the community health workers who can help us reach.
Yeah, easily and connect with them, connect with the community health workers. So they stay with them in those areas. If they have issues, they can connect, and then connection can be much easier.
Maybe that's something also maybe we need to take with us at the time. Maybe another addition to the project. Like we have some people there who would be helping us in follow-up, but we need to provide them with proper knowledge on what to follow. Yes, I think that's another input we can take.
Yes.
The project.
Also, we have another example here too. I think 1 week or 2 weeks ago, we had one patient here with diabetic patient whom we had on regular medication, but later on, after being fed by different people from different areas, then they stopped to continue taking medicine. Then once they come, they had severe diabetic foot, which then was referred to Msoma, then come back here. When we saw him here, we advised him to go to Msoma for amputation. He is already amputated, and he had low blood level put several units of blood, and he's still on antibiotics and the dressing of that wound. So the impact of diabetic is sometimes very high in our area.
Yeah, you see that even in our area, the impact is just getting much bigger and bigger, and people are really getting amputated. Some that if preventive measures can be done earlier, it can be so helpful for them. And what we saw, like in our program there in palliative care, we have volunteers that are coming from different areas, and we have impacted them with basic knowledge. So when we find a patient, because we take their initials and their contact and ask which a particular place are you coming from, so we know that somebody is there, so we connect them. So it is much easier for them if they have a problem. They can contact that volunteer, and then the volunteer will call us, and then we connect easily. And in such a way, of this factor of this local hub is a real big problem. So those volunteers have basic knowledge, and they follow up because they know even those traditional healers, they know them. So we find even time to visit, because we are lucky that we have no home, or we can visit once in a while. So we talk with them in a friendly way, and we also understand. So that has been so helpful to some of our patients. So the program is really good, and I trust that in the long run you will do a really great job.
I think we have element of home visits, and we've been doing it, but mostly we've been doing it for some people around this home township. We haven't moved far to some very local regions of the district. But with your input, I think we can think about that. Maybe if we can bring a car there, we can have someone we can organize like a teaching activity, and then we have some people who will be helping us around. And maybe we take that.
There's a small contribution on the data question of the difference from Nadine. I also think that, because I don't know if it was shown, there's a difference in age. They talked about, you talked about it when you were discussing your data,
Yeah.
that the people in Soma were older than the one we screened in Boom.
Yeah.
So that was just, beside the other facts
Yeah.
you said, it's also one factor was that there was a difference in age.
Yeah. So maybe the high prevalence of diabetes has been shown among could be attributed to advanced age.
Yeah, advanced age.
Yeah. Sunday. Okay. Thank you. Oh. You have one last question? Yes.
Okay, my question is that you have big examination, and you found that you have a number of obesity and other is overweight. So you have to know the difference between these people, obesity and overweight, because some people with overweight can get weight through exercise. Yeah, they become overweight with exercise. Yeah? So I want to know how overweight will you wake up. One criteria if you are finding a different kind of person.
If I could take you back to the data, the body mass index, we have ranges from 25 to 30. That's overweight. When you go into the extreme, you are going to be obese. You start with overweight, then you are going to obesity. And as we are going on with the project, we had some inputs like, sometimes obesity is not that actual measure of the central obesity of the BMI is not the good measure for central obesity. So we were recommended to the waist circumference, Kwa hiyo ni ile obesity na overweight ni spectrum moja. Tunaanza na overweight alafu naenda kwenye nini? Kwenye obesity. Sio kama unanielewa?
Yaani ninakuelewa.
Lakini another question we are raising is like when you exercise, then you become masculine, then you become overweight. Maybe we maybe also need to make a study or research to see the weight gain among those who are exercising, not exercising, but for how most of the time for masculine exercise, masculine exercise most is now add weight kwenye arms, kwenye chest,
back of the chest.
but I don't. We need to make follow-up exactly to see if there are changes in terms of body mass index. But with waist circumference, I'm sure you will not much. If you are exercising, it means you burn your fats. Your central obesity is getting off. But maybe with that weight gain of the arms and the extremities, that needs to be researched.
I'm sorry. Kwenye presentation labda mngepia could trick those people who are aware about their condition and those who are not aware.
Okay, the percentage wise.
Yeah.
Actually, this was just a free issue of fully kama report. We are taking it's just kwenye na ndio sababu pengine presentation ilikuwa kubwa lakini
I'm talking that because the aim is to educate,
yes,
to make people aware about their condition. Because most of people, for example, in Serengeti, they are not aware of these diseases. Even if the doctor can explain they are given a single dose, they go forever. They don't turn back. Even if you tell them to come back, then they come back and then they start to explain. I started to use local herbs here and this one because of some myth concerning these diseases. If you use those drugs, because they are long use forever for your whole time. Wengi wanaogopa kuendelea kutumia hizi dawa, anakuta na vitunguu saumu, sio vitu gani na vitu, unakuta ile pressure inazidi kupanda.
I think the concept he's raising is very genuine, but we should also know that the level of awareness is like subjective. What we included as the universal package in this screening, everyone who was screened was given like a card with the readings of the blood pressure, blood sugar, the body mass index, and we did the interpretation for everything. And counseling, like now your blood pressure is okay, your blood sugar is okay, maybe your body mass index is high. So what do you need to do for this? So we give it. We are giving the education as to the patient parameters and the follow-up that need to be done with every plan. So all these plans we have screened, they have those. We are giving those best education, but this is not something that's sometimes we don't change overnight. So we educate today. Then she comes the other day. She said, you told me, but I couldn't afford. I cannot do the exercise 30 minutes a day. Then you just try to cancel and change the other way of teaching. And I think that's what's going to be presented by the next presenter about the way of communication skills. So that's why we are trying to share and trying to look at different ways where we can get people to understand. I think we should close this, right?
Mm-hmm.
Thank you for your attention. Thank you for following up.
We have the workshops here.
You're going to the workshop?
I was putting them, they were in the other rooms, I got them.
kwenye hizo workshop zetu tutapigawane
Cardiovascular disease and measures of rectal index. It has a small presentation, but also exercise measurement. There is stress reduction and psychosocial care, communication, and then will be given by Dorothea from Canada, and there was a physician. So I don't know if people want to they go to this there or they want to do here first, they go. The physiotherapy, what would be a physiotherapy here? Is it in the physiotherapy? What we also do is because the physiotherapy is also in cardiovascular disease. And I have a small presentation for cardiovascular disease. Like we did last time. Can you put the peer on?
And then
for the measurement, we need the beds. And after that one is inductive.
so should we try kuna vitu viwili, kuna workshop mbili tumeshauriwa na daktari, kuna physiotherapy for peripheral vascular disease. Kwa hiyo tutakuwa na ka workshop hapa, kuna ka presentation kidogo, alafu tunaweza kwenda hata kwenye physiotherapy kule kwa nini, kwa ajili ya hiyo mazoezi na demonstration. Lakini kuna stress reduction, psychosocial care and communication. Kwa hiyo tunataka tutaenda kutumia receptor corner, tutakuwa tunaendelea kwa tunatamani kupata mafunzo mawili doane ili tuweze kuendelea. Yes, so can we start this right now and then the afternoon we exchange like the members over here?
Yeah, that's
Kwa hiyo nafikiri hiyo tumeelewana. Labda sasa hivi kwamba tujigawe kwenye kuna ulizo. Tuende kwenye yani ndio tunataka kwenye alafu baadaye ile amena exchange. Kwa hiyo kwenda kule
kwa maana ya ikiwa wachache zile kutarati vizuri na kwa rahisi. Na
maybe we combine because also it's connected. Congregation ni muhimu mwenyewe.
Stress reduction and psychosocial care and communication
in the preceptor corner, and Mary Odon will be leading the physiotherapy for cardiovascular disease here, right? Kwa hiyo tusigawe sasa, anaotaka kwenda
tuhesabu tu.
Let's count the number and then we. Okay, so 1, 2, 1, 2, 1, 2, 1, 2.
2. Tuende juu.
1, 2.
1,
2.
1, 2.
1,
1,
2.
1.
Hapo umeshamaliza bado.
If you give one, okay.
Yes. So, nimewaacha hao facilitators wetu kwa sababu ya yani they are known, si ndio? Unafanya namba moja namba mbili. Moja mbili, unapenda moja mbili, moja. So
we means
unaendelea moja mbili.
kwenye group hiyo.
Wewe uko physiotherapy moja. So number 1 will be only physiotherapy. Physiotherapy for peripheral vascular disease. Kwa hiyo sababu namba 2 stress reduction. Si ndio? So we can go in our respective areas, right?
Yeah.
Namba moja unabaki hapa. Namba moja unabaki hapa.
Yeah, maybe we should.
Namba mbili.
There's only one question, same model as namba ngine unachukua tu
one is we are back forward. We are back forward. We are back forward. Would you like to remain for physiotherapy?